This will be very brief. This is a video that Sammy Goldman helped me edit for bone marrow aspirate concentrate. We can do this from the proximal humerus at the time of a shoulder surgery. We can do it from the proximal tibia at the time of a knee surgery. We can do it from the anterior iliac crest for any supine position and or prone position to do the posterior iliac crest. From my perspective, when you look at the data that shows stem cell surface receptor count, FCU and so forth, the best is probably the posterior iliac crest followed by the anterior iliac crest. Then maybe the distal femur gets in there somewhere. We don't use the distal femur very often. And probably my guess is the tibia is somewhere near where the proximal humerus is. So we use this procedure as an adjunct to surgical intervention, although many I know are now doing it office-based for the treatment of osteoarthritis. So what we'll do now is run the video. It's only about 1.5 minutes, and then we'll let you guys move on. And I could just continue to narrate if that's correct. Okay, great. All right, so on the back table, basically, they will fill the syringes with an anticoagulant. I'll typically use local anesthetic at the anterior superior crest just to know where I'm at and to numb the area up for postoperative pain relief. I no longer make an incision. I go right through the skin with the sharp trocar. We'll typically go in about 3 centimeters, and in an effort, we'll start deep, so we're in between the inner and outer tables, making sure we don't deviate one way or the other to avoid inadvertently penetrating. And then what you don't want to do is just start drawing it back and assume you're getting MSCs. These MSCs exist as pericytes on the lining of the trabeculae. So what you really want to do is expose the openings of the trocar to the trabeculae. So what we'll do is we'll get about 3 to 5 cc's, then turn it 15 degrees, and then we'll keep drawing it back about half a centimeter so that you're always getting fresh exposure to the trabeculae. We'll do this for a total of 60 cc's. If you can't get a full 60 cc's, this system will allow you to add peripheral whole blood to balance out the centrifuge. And you can actually do more than 60 cc's. Then it takes about 15 minutes to process it. And then what you get back is a concentrate of typically 3 to 5 cc's, where in this case we're doing a shoulder with a rotator cuff tear repair as part of a clinical study we're doing. We'll inject into a dry field, typically with direct visualization. So I know that was quite fast. I think from a technical point of view, as I mentioned, the ASIS is very good if you're using a beach chair position because you can get down or a laying down position where you're supine, because you can get to the knee obviously very easily and prep the ipsilateral crest. Similarly, you can do a shoulder procedure by first prepping the crest and then sitting the patient up in the beach chair position. If you're doing lateral decubitus and you want to use it, obviously the posterior is easy. I just don't like flipping the patient back and forth. I don't think there's enough data that tells us that one is definitively better than the other. You can get platelet poor plasma as well as part of the BMAC when you're doing this procedure, but we'll typically just use the BMAC, the bone marrow aspirate concentrate, for the definitive procedure.